Great. So welcome. Thanks again for the organizers for inviting me to speak on contemporary management of brain metastasis. Thank you for the TAROS organization and Tastro. So I'm Tony Wang. I'm a radiation oncologist at Columbia. I do mostly CNS and brain tumor at my institution. And these are my disclosures, and they're electronically available. So the key objectives in this talk is to explain about the current treatment paradigms for brain metastasis management, discuss potential strategies for different brain metastasis clinical scenarios, and then just go over some practical brain metastasis cases as well as medical decision-making strategies. So I'm just going to go over some backgrounds on brain metastases. I imagine most of our audience here are radiation oncologists who already know a lot about brain mets. I'm going to show some sample cases, some of the SRS data, ongoing completed phase 3 trials, as well as some of the more recent literatures on brain metastasis for post-op radiosurgery. So, brain metastasis is one of the most common primary or secondary brain metastasis tumors in the United States. There's about 300 annual incidences per year. About 20 to 40% of adult cancer patients will develop brain metastasis throughout the course of their cancer treatments, and about 6 to 10% of pediatric patients will develop brain metastases at some point. 2/3 of them are symptomatic, and a third to half the deaths are related to brain metastasis failure. So this is an old study, but I think it's somewhat relevant, and I'm going to talk about why. So this is a study by Roy Patchell looking at one of the first randomized trials comparing whole brain radiotherapy versus surgery followed by whole brain radiotherapy. One of the first randomized trials that actually looked at this question. So these were patients who had a single brain metastasis with a decent Karnofsky performance status of 70 or greater. They received doses of 36 gray and 12 fractions, and they did not have leptomeningeal disease. And what Patchell found was that those patients that had surgery followed by whole brain radiotherapy, specifically for a single brain metastases, did in fact have an improved median overall survival of about 9 months versus 3 months in those who just got whole brain radiotherapy alone, suggesting that even with single brain metastases, the benefit of surgical resection probably outweighed just doing whole brain radiotherapy alone. And this kind of led to more of the data that we found with radiosurgery, which is kind of the bulk of what we do now in our practice. Again, this is a paper that was published almost 20-some years ago, so there's been a lot more developments, as most of us know. And then following that, Roy Patchell then published the other paper, which was, again, patients who either got surgery with or without whole brain radiotherapy, right? So again, just to summarize, all patients patients who were randomized to the whole brain radiotherapy arm got 50.4 gray and 28 fractions. We obviously no longer use this dose fractionation, but again, this was a paper that was published in the 90s, over 20 years ago. So patients were eligible if they had single brain metastasis that was gross totally resected, and then randomized to whole brain or no whole brain. And what they found was those that had whole brain radiotherapy had a lesser recurrence in brain versus those that get surgery alone. 70% had a recurrence in their brain if they didn't get whole brain radiotherapy. And then the recurrence at the resection site was 10% if you got whole brain, or 46% if just surgery alone. And this is fairly consistent if you look at some of the more recent phase 3 trials. And then the rate of neurological death was a lot lower at 14% if you got whole brain versus 44% just by surgery alone. So, but there was no difference in survival with whole brain. However, it did improve neurological death if you were to get whole brain versus just surgery alone. So SRS was popularized in the early 90s. This is a study by Ed Shaw at Wake Forest looking at the different dose fractionations of SRS, and this is what kind of has made us relevant in terms of how we do dose fractionation for radiosurgery. And initially, these were the radiosurgery dose fractionations were based on diameter. Right now, a lot of our data is based on volume, but if you take it as it was, this is a study activated in 1990. Right, the first 2 letters of RTOG is essentially the year in which it was activated. And so what they found was that they did dose escalation using Gamma Knife and Linac-based radiosurgery platforms. This is activated prior to the advent of CyberKnife. For tumors that were less than 2 centimeters, they started at 18 gray and they maxed it at 24 gray. And then for 2 to 3 centimeter diameter brain metastases, again, these are intact brain metastases. Patients were then started at 15 gray and then maxed out at 18 gray because they detected toxicity at 21 gray for these kind of tumors. And then for the 3 to 4 centimeter intact brain metastases, the study started at 12 gray and then maxed out at 15 gray as it detected toxicity at 18 gray. So the keynote from the RTOG 9005 was if you had 2 centimeter or smaller brain metastases, you could go up to about 24 gray max tolerated dose, and then 18 gray if it was 2 to 3 centimeters. And then, of course, if it's larger than 3 to 4, you could do 15 gray with a 10% risk of radionecrosis. So key points was that in the 9005 data, the radionecrosis rates was about 10% using those dose fractionation regimens. And that kind of set the stage of how we designed our SRS delivery, as well as dose fractionation for the ongoing radiosurgery trials. And I'll discuss them in later slides. So as we know, the neurotoxicity is going to be a lot greater for larger tumors or higher dose. And the risk of progression was kind of similar by the different platforms. And this also led to, when we do SRS, for those that are, either radiation oncologist or physicist, our understanding of conformality index, which I think is important, as well as heterogeneity. So following what I discussed with the Royal Patchell paper, this is a paper by Andrews et al. Looking at patients who had brain metastases who were randomized to whole brain with or without radiosurgery, right? This is now, we now understand radiosurgery is effective. We now kind of have an idea of the maximum tolerated dose. And these were patients that were, again, randomized by whole brain plus minus SRS. Those that had a single brain metastases who got SRS had a slightly improved median overall survival of 6.5 months versus 4.9 months if you just got whole brain radiotherapy alone, indicating that, well, yes, SRS didn't necessarily improve overall survival, but it did help increase local control and also did seem to improve patients' survival, and especially in patients that had a single brain metastases versus multiple brain metastases. So I can't really talk about brain metastases without going over some of the prognostic indexes that we use now, right? The diagnostic-specific graded prognostic assessment. This is by Paul Sperduto at Duke, basically incorporating a lot of the NRG data as well as other institutions' data to prognosticate patients who have brain metastases stratified by their primary tumor. So non-small cell lung cancers tend to do better, depending on their molecular features as well as other cardiovascular performance status, extracranial disease status. Breast cancers also by their molecular markers now, right? The patients who are triple negative tend to do a little worse than those otherwise. And then, of course, like the GI and then cancers tend to do a little bit worse for the most part. There is actually an app you can download from Paul Sperduto. I think it's called, I think I had it before. Let me go back. It's an app or a website. You can actually download a GPA index and get a prognostication for your patients who have brain metastases for the most part. But this has gone multiple versions of papers, specifically by their diagnosis. So I want to show you a couple examples of brain metastases cases, right? So on the left, you have a patient that has perhaps a single metastasis, you can see on T1 post-contrast on the left temporal lobe. On the second one, you see a patient that has maybe perhaps 3 and then 1 larger brain metastasis in the right occipital lobe. And on the right, this is a patient that has essentially miliary innumerable brain metastases throughout the brain. And when I was in training, patients that presented just with a single brain metastasis, I don't think this has changed. I would say, we still pretty much would have offered radiosurgery at the time. And now we would probably still offer radiosurgery. Actually, even now, depending on their type of primary histology, my neurons sometimes may even continue systemic therapy and not offer radiosurgery, which I sometimes disagree with. And then the patients who presented with 4 to 5 brain metastases, I can tell you, during residency training, this patient would have gotten whole brain radiotherapy prior to some of the more recent data that we do now. But now, with advent of SRS technology, I would say for this we would still offer SRS versus what I do before. And then, of course, then you have a patient that has essentially innumerable brain metastases. And I think the differences between then and now is a patient like this, I'd probably still offer whole brain radiotherapy. However, with some of the new CNS penetrating systemic therapy options, my medical oncologist may just offer targeted therapy that they want to keep observing as opposed to just giving whole brain radiotherapy. So I don't know if that's the practice that's been kind of more prominent here in Taiwan, but it's just, these are some of the changes I've noticed in the last couple of years. So these are randomized trials of patients who have brain metastases who got radiosurgery with or without whole brain radiotherapy. These are 4 sort of prominent trials that have been published in the last decade looking at the overall survival in patients who have limited brain mets, who got SRS followed by whole brain or not. And some of the takeaway is overall, the addition of whole brain to SRS in patients with limited brain metastases. I'm defining limited brain metastases by 3 to 4 brain mets. At least that's what most of this eligibility criteria for the 4 trials here, right? This is a JROG. This is a Aoyama paper from Japan. This is by Eric Chang when he was at MD Anderson. This is by Coker et al. From the European group, and this is by Paul Brown, who was at, I think, at Anderson at the time. So essentially, adding whole brain radiotherapy to radiosurgery in patients with limited brain metastases didn't seem to improve overall survival, and that was my point. And then in 2014, one of the first papers of using radiosurgery for multiple brain metastases, right, was by Yamamoto from Japan, where they did a multi-center observational study on over 1,000 patients, right? Patients who had upfront brain metastases, of either 1 brain metastases, 2 to 4, or up to 10 brain metastases, who all got upfront radiosurgery. And I believe in this study, it was mostly only gamma knife usage as opposed to Linac or CyberKnife. But essentially what they found was, you know, this is a Kaplan-Meier survival curve of patients who have a single brain metastases. That's the green line, right? And then if you looked at patients who had 2 to 4 brain mets, as well as 5 to 10 brain mets, the survival actually was very similar, suggesting that you can do SRS for more than just 4 brain mets, right? So that was kind of the first sort of study. Then, at that point, there was really no randomized data looking at SRS for more than 4 brain metastases. So this sort of led to like, well, yeah, we can do gamma knife radiosurgery for way more than just 4 brain metastases. And then, of course, after Aoyama published that paper in 2014, this was followed by the Hughes study. This is a multi-center study in the United States, published in 2019. Again, looking at, well, let's look at upfront radiosurgery in the US. Again, the survival, this is again the survival curve. It was very similar to the Japanese data, right? So this is the survival for patients who had a single brain metastases. And then this was the survival for patients who had 2 to 4 brain mets, and then 5 to 15. Again, only patients who got upfront radiosurgery as opposed to whole brain radiotherapy. Again, not randomized data, but this is multi-center retrospective studies. And so what they found was like, okay, yeah, so even if you had brain mets of 5 to 15, frankly, the survival wasn't that much different than those at 2 to 4. And the reason why this is important was because patients who had more than 4 brain mets, essentially, the standard treatment was to give whole brain radiotherapy for these patients, right? Which we now know is not really necessary. You can actually, you don't have to do that. So I think those 2 papers, both the Aoyama paper as well as the Hughes paper, sort of led us to pursue more of the upfront SRS studies. So these are some ongoing. These are ongoing studies right now that are, and some are closed currently, that are randomizing patients to radiosurgery plus whole brain radiotherapy. So if you saw my prior table, those were the Aoyama, the Eric Chang, the Coker, and then the Paul Brown. Those are the 4 trials really published in the 2000s looking at radiosurgery plus minus whole brain. But they were only for patients that had brain mets up to 4, right? What I'm harping on these are now specifically looking at the question of more than 4, right? So that'll help answer that, because frankly, what we're doing now, we don't really have any randomized data looking at that. And hopefully these will help answer that question. Additionally, the whole brain option for those patients are really hippocampal sparing avoidance whole brain radiotherapy for the most part. So this will really, I think the results of these trials will really help answer that question about, you know, what do we do with patients that have 8, 10 brain metastases, right? Because a lot of places that I know of still do just radiosurgery for multiple brain metastases, but we just don't have any really phase 3 data to tell us whether that's better or not. And additionally, what about neurocognitive? Which I consider to be just as important is neurocognitive outcome in these patients. So I'm looking forward to some of these studies, right? There's it's all over the place, including in Europe and Canada, as well as institutions in the States that are looking at this question. So we look forward to that. Now, I think most of us who are radiation oncologists or physicists or radiation therapists, if we're talking about brain radiation for brain metastases, we probably do a lot of hippocampal sparing radiation. So this is one of my papers by my colleague Vinay Gandhi, looking at dosimetric profiles and techniques to do that. Usually I use a T1 without contrast MRI scan. Sometimes I'll use a T1 with contrast. And if you have a contouring software that just does auto segmentation for you, sometimes it actually just auto contours the hippocampus for you. I mean, you still need to check, but I think the technology is getting better and better for these contours. And then you do a margin around the hippocampus, and then you want to keep your dose constraints per the NRG CC0-1 study, which is at D100% less than 9 gray. I think you can go up to 10 gray for variation acceptable. And then there's the Dmax of less than 16 gray with some flexibility in terms of its to be within the CC0-1 criteria. So speaking of which, again, this paper has already been published a few years ago. This is NRG CC0-1. I think most of us are probably familiar with that. So again, these are patients that have brain metastases that were randomized to your standard conventional, lateral opposed beams, 30 gray and 10 fractions with memantine, or they were given hippocampal avoidance whole brain radiotherapy, which I showed you the technique before that. And the primary endpoint was to determine whether hippocampal avoidance whole brain radiotherapy increases time to neurocognitive decline at 6 months, right? So that was done through the this is important, I think, because it's always, when you're talking about neurocognitive testing, neurocognitive improvement, I think we should know exactly what kind of neurocognitive test is being done on the patients. So they were done using the Hopkins Verbal Learning Test, recall, the COA, the Controlled Oral Word Association, and then the Trail Making Test A and B, right? So these are patients that would get these tests at baseline at the time of randomization, and then after whole brain radiotherapy, they would get these tests done every 2 months, essentially. So I don't know how familiar people are with it, specifically with these tests. Does anyone are familiar with it? No, not really? Okay. Because I really think it's important. I used to do this with my residents too. I said, yeah, you keep telling patients that by doing this is better, but so what are the tests? And they have no idea. I'm like, no. You're all getting certified for this. So I think this is great because I know a colleague here at NTU that's actually doing something similar like that, but in Mandarin. It's great. So we'll do this test, actually, it's great. So I think this would be helpful. So let's talk about the Hopkins Verbal Learning Test. So if you're not familiar with that, you can check it on Google, you can find it. So you basically get a list of words, you give it to the patient looks at it, but this is English. And then you let the patient look at it. And then you ask them at different time points to recall as many words as they can at a particular time. It's like up to 5 minutes, there's a 1 minute, there's like a 5 minute, and there's like a 30-minute one. And they're scored based on how much they actually recall. Okay, that's basically it. And then they do this every time they come for testing every 2 months, right? And then if they, obviously you want to make sure that they maintain how much they recall and that doesn't change over time, okay? The Control Oral Word Association Test, the COA, again, you can find this on Google. So you give a patient a letter, and then within a minute, the patient has to say the words that start with that letter, but it can't be pronouns. So if I say, okay, tell me all the words you can think of that starts with F. You can't start with oh, Frank. Like, no, that's not. You have to food, French fries, and you just have to say as many as you can. And then it's basically testing how many words you can say that does that testing for you. And it's a way to measure someone's neurocognition. All right, there are some limitations with these techniques, but I'm just telling you this is kind of what was done. And then the other parts are the trail making test A and B. So basically for those, a patient gets a diagram, and there's different there's different letters for numbers, for example, and the patient is timed connecting the numbers in consecutive order, and they have to finish it. And if they make a mistake, they start over. So it's timed. They're timed as to how soon they can complete connecting the numbers. B is like a number and a letter. So it's like 1, A, 2, B, 3, C, right? You can argue like how much it translates to neurocognition, but this is exactly how the testing were done to measure how patients do neurocognitively, right? So that's, I always think, like, if you're gonna do a study that's based on neurocognitive deficits, it's really important to know exactly how it was tested for these patients. So that's what we're done for all these patients at baseline and every 2 months, because that was the primary endpoint. So what they found was that patients that got hippocampal avoidance whole brain plus memantine, the time to at 6 months who developed neurocognitive failure was 59.5% versus 68% that just got conventional whole brain radiotherapy. Right? This is the 2 lateral opposed beams, and it had a hazard ratio of 0.76 with a P of 0.03. So there was clearly a separation curve, right? So this is 0. This is by months: at 2 months, 4 months, 6 months, 8 months, 10 months, and then 12 months. And you can see there's already a fairly sizable separation of curves at this point where they looked at the different neurocognitive endpoints. So the solid line here is the higher it is, the more patients had neurocognitive failure, right? So you can tell that as early as 2 months, 4 months, the patients that got standard whole brain therapy, quite a bit of them developed neurocognitive failure, right? Versus the hippocampal avoidance, which you can argue it's better, but clearly patients, even with hippocampal avoidance, will still develop neurocognitive decline, right? But I would argue if I had to choose one or the other, I'd obviously choose the one that's the lesser of the 2 evils. Okay, so I just think this is very important because if you're not familiar with it, I think this is sort of like the baseline of using spare radiation. This is something that we as radiation oncologists can try to control for patients, right? Memantine is memantine, that's prescription. But how we design the radiation plan, how we can make the patient's quality of life better, this is something that we can control in our field as opposed to our medical oncologist or neuro-oncologist. So moving forward, other things that I think are helpful in terms of brain metastases is the management for large brain metastases, right? So not every patient can come with 10, 15 brain metastases that are very small, that are not amenable to surgery. You just give whole brain or hippocampal whole brain radiotherapy. But oftentimes I'll see patients who present with very large lesions that, if they're symptomatic, I think we all know here that just giving radiation therapy alone may not be effective enough and may not help with symptoms, right? So a lot of these patients oftentimes will require surgery. And then the question is what do you do after surgery for these patients, right? Is there a clear standard? Because after, this is just an example of a patient that had a fairly large right cerebellar brain metastases, and then, had to my eye, it looks like a gross total resection. This is a T1 with contrast MRI scan. And if you don't give any sort of adjuvant radiotherapy in a patient that has a gross total resection, I would tell you that there's a 50% chance at 1 year they're going to have recurrence in that spot, right? That was shown as far back as the Patchell study, Patchell 1 that did surgery with a whole brain, right? About 50% recurred. And then I'll show you the 2 other phase 3 trials that looked at recurrence rates to the surgical bed after the surgery, after surgery without whole brain radiotherapy. So just another example of, cases where you have a patient, like in this case, with a right occipital brain metastases, likely symptomatic, and has gross total resection. What do you do in this situation? So this is one of the first phase 3 trials looking at this question by Anita Mahajan when she was at Anderson. So she randomized about 132 patients who had 1 to 3 brain metastases. Everyone had to get a gross total resection. So to be eligible, you had to have 1 to 3 brain metastases, and then at least one of them had to be gross totally resected. So if you had surgery, but there was still residual brain mets, you weren't eligible. So this is like the best of best players, right? You had a complete resection. Sometimes my neurosurgeon would just say, oh yeah, I did a gross total resection. I don't need to do anything else, right? But I would argue, so that was the question they were answering was, okay, so even if you got a complete gross total resection, can you really omit radiosurgery to the postoperative bed? So the study was you either got SRS or you just got observed. The maximal resection cavity diameter could be only 4 centimeters or less. So it was a pretty, as a 1-to-1 ratio arm, about half the patients were radiosurgerized, the other half was observed. And then what they found was this is a local control progression from surgical resection at 1 year. And this is local recurrence, freedom from local recurrence, excuse me. So at 1 year, this is the 12-month curve. The 1 year local control rate was 73% with radiosurgery. And then if you didn't get any radiosurgery after a complete gross total resection, only 43% of patients had 1 year local control, meaning more than half the patients who didn't get adjuvant radiosurgery failed at the time of their surgery, at the site of their surgery. Forget about distant elsewhere brain metastasis recurrence. Just the area that was resected that didn't get radiation therapy recurred at the site of the surgery. So I would also argue that some of the post-op radiosurgery doses here are a little low than what I'm typically done. So for patients that had a surgical cavity of 10 cc or less, they got 16 gray, and then if they were 10 to 15 cc's surgical cavities, they got 14 gray, and if it's more than 15 cc's, they got 12 gray. So, and I'll argue that, but this was I point this out because if you are in a practice where you do brain metastases and you have a patient that had surgery, and this is discussed at a tumor board, I would say, look, we actually have now at least 2 randomized trials that looked at this study. If you don't get surgery, more than half the time your tumor is going to recur, I would argue you should just do adjuvant therapy to the surgical cavity. So this is the N107C study by my mentor, Paul Brown. But, again, these are patients that had a gross totally resected brain metastases up to 4 brain mets. And then they were either given radiosurgery to the cavity or whole brain radiotherapy after surgery. And the primary endpoint was looking at cognitive deterioration-free survival. The secondary endpoint was overall survival. And what they found was this is just looking at surgical bed control, meaning after you do surgery and then you give radiation, whether it's radiosurgery or whole brain radiotherapy, at 1 year, what was your control rate, or essentially local control at the surgical site, right? So, with radiosurgery at 1 year, the control rate was about 61%. So, meaning that even if you give radiosurgery to the cavity, I would say that what this tells me is that 40% of the patients are going to recur at the site, all right? With whole brain radiotherapy, it's 81%. But the survival is no different. But I think that wasn't the primary endpoint, because what they were looking at was really neurocognitive deterioration. And what they found was that those who got whole brain radiotherapy, no surprise, had worse neurocognitive function after the radiation therapy versus radiosurgery. But this is sort of an example of what do we do with large brain metastases and their outcomes? So for large intact brain mets, in this study, this is from our colleagues in Italy, where they defined as any intact brain mets, meaning any brain metastases that were not resected, that were there, that's more than 2 centimeters in size, to single versus fractionated radiosurgery, they looked at local control rates. And the question the Minetti et al. Was looking at was, well, does fractionated radiosurgery, would that have better chances of control versus just single fraction radiosurgery? And if you did single fraction radiosurgery, their doses were 15 to 16 gray for tumors that were larger than 3 centimeters, or 18 gray if they were 2 to 3 centimeters. And then for the fractionated, they just gave 9 gray times 3 for all patients. Okay, the BED for the fractionations was about 50 gray, except for the ones that had really large brain metastases. So I think the take-home point here is that what they found was if you did the 9 gray times 3 regimen, the 1 year local control rate was actually 90%, 91% versus 77% for the single fraction radiosurgery. And then also I think just as important is the 1 year rate of necrosis. For the fractionated radiosurgery, 9 gray times 3 was 9% at 1 year versus 18% with single fraction radiosurgery, right? Because these were the larger brain mets. So I think we all agree that there's a higher rate of radionecrosis rates if you do radiosurgery in that case, suggesting that perhaps we should consider fractionated radiosurgery for larger brain metastases. So, well, what about surgical bed control? Well, I just showed you that for those that are So the slide before was for patients that had intact brain metastases who did not have surgery, but these are now specifically looking at patients that had surgery after for their brain metastases. So if you look at single fraction radiosurgery data, so both for our institution, this is our paper here at Columbia. If you look at Dr. Mahajan's paper and Paul Brown's paper, the N107C studies, the 1-year control rate at the surgical cavity, even after radiosurgery, for single fraction radiosurgery, kind of hovers around as low as 60% to as high as 80%. But then if you look at the post-op, the fraction radiosurgery outcomes, it's actually pretty good. So this is just another study that I'm looking that was published from I forgot what country it was, but basically it was a phase 2 hypofractionated radiosurgery data. Now I'm pointing this out because this is one of the concerns I have with when you're doing fractionated radiosurgery, the doses. I think hopefully this gives you some idea and concern. Is this is a study in patients that had post-op brain mets, single brain mets that had greater than 2 centimeters in size, and then instead of 9 gray times 3, the study did 30 gray and 3 fractions within a month of surgery. And what they found was the local control rate was 99% at 1 year. However, the grade 2-3 radionecrosis rates was almost 26%. Now, I don't know about you, but that to me is really, really high if you have a 26% radionecrosis rate at 1 year. So that's 30 gray and 10 fractions. There's, I may not have shown this in my previous slide here, but there's a South Korean paper. It was published in the Red Journal about, I think, 2 years ago that looked at 8 gray times 3, 9 gray times 3, and 10 gray times 3 in patients with brain metastases and large brain mets. And what they found, I thought I put in the slides here, but you can probably find it online, but what they found was that the 9 gray times 3 had similar control rates versus the 10 gray times 3, but a lower radionecrosis rate. So I personally, if I'm doing fractionated radiosurgery, both with the Minini data and the South Korean data, I typically do 9 gray times 3 for the most part, unless they're extremely large. Now I might go 6 gray times 5 for my brain mets. So for that, oh, sorry, let's move on, next slide. So these are other ongoing studies that I think are of interest. So this is NRG BN0112. So this is, it just activated a few months ago. So these are patients that have, actually not a few months ago, excuse me, this is Stuart Burry's study. This is patients that have at least 4 brain metastases, but one of them has to require surgery. And the question that Stuart, or that the group is studying is, is pre-op SRS better or post-op SRS? And the argument, and the primary endpoint is looking at local failure versus overall survival, for example, as well as rates of nodular meningeal disease or leptomeningeal disease failure or radionecrosis. So, so the pre-op SRS, I don't know how often people do it here or not, is you have to do the SRS within 7 days of the surgery. So if you identify a patient that is going to go for, has brain metastases, is going to require surgery, you would then enroll them and then try to do radiosurgery as quickly as possible, followed by surgery within 7 days. Or you would do, I think what most people do, like myself, you would do post-op SRS after surgery to the resection cavity. So hopefully this will help answer the question, maybe whether pre-op radiosurgery was actually going to be better versus what, because some of the data right now for pre-op radiosurgery seems to be fairly favorable, at least in the retrospective setting. So, I've noticed that people published that maybe there's less rates of leptomeningeal disease progression with pre-op radiosurgery and maybe less rates of radionecrosis, but this study will hopefully answer that question as to which is the best approach to treat patients who need surgery. And maybe just doing radiosurgery before that might actually be the better choice, or still post-op. So this is ongoing. I don't imagine it. It's still accruing. I don't think it's going to be closed or it's going to be published within the next couple of years. But it'll help answer that question. So I think I just moved the slides differently. But this is the South Korean paper that was published in JNS in 2019. So the authors did dose escalation fractionated radiosurgery for large, as in 3 centimeters or more, intact brain mets, right? They did 8 grade times 3, 9 grade times 3, or 10 grade times 3. And it was patients who had a single brain metastases greater than 3 centimeters in maximal diameter, who were given 24 gray, 27, and 30 gray. And so the first figure here is to look at local progression-free survival. So the blue is the 8 grade times 3, right? But then the red and the green are the 30 gray and then the 27 gray. So the local progression-free survival data is fairly similar, whether it's 27 or 30. But then here, this figure here is the cumulative incidence of radiation necrosis, right? So with the 8 grade times 3, it was 0%. Nobody had radiation necrosis. And then the 9 grade times 3, it was like 13%. But then if you did 30 and 3, it was like 37% by 6 months. So this kind of convinced me to just basically do 9 grade times 3 for my 3 fraction radiosurgery patients, right? At least the data to me was convincing enough to do that. And I hadn't found anybody like better, and the control rate seems to be decent for that. So I think I'm till 9:50, but I'll just keep moving on. So this is a phase 3 trial that was just activated a few months ago with an NRG. It's by my colleague Rupesh, Dr. Koticha, excuse me. It's a phase 3 trial of single fraction radiosurgery versus fractionated radiosurgery for intact brain metastases. So these are patients that have up to 8 brain mets. They have to have a decent ECOG performance status. They cannot have had prior radiation therapy. And the tumors can't be more than 3 centimeters. It has to be within 1 to 3 centimeters in size. And the randomization is single fraction radiosurgery, stratified by the size of the tumors, or fractionated radiosurgery of 30 gray in 3 fractions for the smaller brain mets, or 27 gray in 3 fractions for the larger brain mets. The primary endpoint is to see whether fractionated radiosurgery will have better control rates. Secondary endpoints include radiation necrosis. So this is actually, will answer that question, whether fractionated radiosurgery will be better for patients with intact brain mets versus single fraction radiosurgery. And I think hopefully it just activated, I think, last year, so I imagine it won't close to accrual for at least a few more years. But this will help answer that question as to the fractionation approaches for our intact brain metastases patients. Okay. The next thing I want to bring up, this is by my colleague Jonathan Yang at NYU, who's actually Taiwanese, believe it or not. His parents and my parents are both from Kaohsiung. So this just got activated a month ago. And I told him, I said, hey, I'm going to talk about brain metastases. And you just activated this brain metastasis trial. Do you want me to present? He's like, yeah, please do. Apparently, there are 4 proton centers in Taiwan. Is that correct? 3 or 4? I heard 4. And I also heard, like, in Taiwan, you actually can accrue patients in NRG trials. Maybe not. Okay, I don't know. But so he was like, yes, please share it with all the Taiwanese colleagues. Can they please accrue patients in my study? So this is a phase 3 trial. It's NRG BN014. It just got activated like a month ago or 2. It's a phase 3 randomized clinical trial of proton craniospinal radiation versus involved field radiotherapy for patients with breast or non-small cell cancer who have leptomeningeal metastases. So, Dr. Yang had, I think, published or presented a phase 2 trial at ASCO a few years ago, doing proton CSI for patients with leptomeningeal disease. And I don't have the slides for that, but from basically the results seem to be very favorable that led to the phase 3 study. So this is patients have to have breast or non-small cell lung cancer primaries, and they are randomized in a 1-to-1 design to either involve field radiotherapy. So oftentimes I think many practitioners will just give whole brain radiotherapy for patients with leptomeningeal disease, or the arm 2, which is to give proton CSI. So again, this is I think a very interesting study, and it potentially will treat our treatment paradigm for patients with this very, very unfortunate. I didn't do that. Okay. All right. So, is it time? Oh, 5 minute warning. Okay, got it. Thanks. Um, wow. Okay. It's funny. My daughter really knows that song very, very well, and I so catchy. So the primary objective is to compare overall survival between proton CSI and evolved field radiotherapy in patients with breast cancer, non-small cell lung cancer, left untreated. So I think this is a very interesting study because if it's if the results show that proton CSI is in fact improves survival for patients with this very terrible disease, really that really can really potentially treat our paradigm for our patients with this diagnosis. Other secondary objectives that for BN014 is looking at CNS progression-free survival between PCSI and involved field radiotherapy, CNS progression, radiation-induced necrosis between both options. So a lot of quality of life toxicity secondary endpoints, which is, I think, very helpful. So this is the ASTRO brain metastasis guidelines. This was published in PRO, I think, in 2022, and it's just kind of for your leisure, but it kind of has a guideline as to sort of what ASTRO generally recommends for brain metastases. So, if you have a decent performance status of ECOG 0 to 2, you have up to 5 to 10 brain mets. SRS is conditionally recommended. Strong recommendation. Evidence, quality of evidence is a little low. If you have intact brain metastases, we favor single fraction radiosurgery to 20/24 gray. Sometimes for small brain mets, at least for my practice, if the brain met is located in in a very sensitive location in the brain, like a premotor cortex, my neurosurgeon's a little worried. I sometimes will drop my dose to 18 gray if it's small. I still think the control rate's pretty decent for that. And then for larger tumors, fractionated radiosurgery I think is reasonable. But again, this is all published in PRO. It's ASTRO evidence-based guidelines. And then this is like post-op radiosurgery, single fraction radiation dose recommendations. This is based off the Alliance trial, the Alliance A071801 trial. So this for single. But if it's fractionated radiosurgery, I would usually do 9 gray times 3 in patients that have small post-op beds, or 6 gray times 5 if it's a really larger post-op bed. Okay. This is a busy figure, but this is the figure from the ASTRO consensus paper, sort of algorithmically explaining sort of decision-making trees as to how you approach a patient with brain metastases. So I'm not going to belabor the point, but it's available at PRO if you have access to it. I think it's great. This is a paper from my colleague Arjun at Princess Margaret. At Toronto, and for patients that have brain mets in a very, very difficult location, right? This is someone who has a brain met in the brainstem. It looks like the midbrain or the pons eye. Sometimes I've done this too. I'll do stage radiosurgeries. So it's probably very difficult to give this full dose. He'll do 8 gray, 1 fraction, and then 2 weeks later, do another 8 gray, and then another 2 week gap, do another 8 gray times 3. So it's like almost like stage or adaptive radiosurgery for these patients. So I think these are all different approaches. It's very fancy. So just circling back to our sample cases, this is kind of how we've approached it, just to give you eyeball. Things have definitely changed, particularly for patients who present like this for me within the last 10 years. And I imagine it'll keep changing, especially with better CNS penetrating drug therapy. So in summary, I think the management for multiple large brain mets, we have to consider dose fractionation. I think we need to really think about fractionated radiosurgery, hippocampal avoidance radiotherapy, if depending on the circumstances. Post-op radiosurgery by radiosurgery or whole brain radiotherapy. I think that depends on the circumstances of the patients. The DSGPA score is helpful to determine next steps, whether it's more palliative or you want to do radiosurgery. For large brain mets, like I said, I would consider resection and then post-op SRS. And then whether it's single or fractionated, that depends. As I showed you, single fraction radiosurgery is effective, but I think the control rate is still not that great. And I think we can do better than that. So hopefully the fractionated radiosurgery will be better. And then the Alliance trial is looking at the outcomes for the post-op brain mets. Hopefully that the fraction radiosurgery will be better than the single fraction data that we have. So I'll pause here because I think it's 9:49 right now. And thank you for your time, and thanks for having me here.
要询问问题。
Thanks. Thanks, Professor Wang, for the great review. I would like to know that what's your take on the unilateral hippocampus sparing? Do you do that? And
So I don't do. I actually.
yeah, because I've seen some discussions about that.
So it's an aspirational objective.
Yeah.
For are you saying for gliomas, or are you saying for everybody?
No, for yeah.
Yeah, I mean for brain mets, if I can spare both, I'll spare both. If I can spare one, I'll try to spare one. I actually do it for gliomas too. So like for example, but again, the dose is really different, right? You're doing 60-30 or 59-4, 54. So I have like aspirational dose constraints to the hippocampus on the contralateral side.
Yeah.
I don't know if it's effective. It's just sort of like, that's what I would do if it were me.
Okay.
Right. So I think that's a little controversial. I don't have a strong point because I don't think that there's a lot of data with unilateral, but I do try to spare that for my patients if I can, gliomas and not. Brain mets, not so much. I'll say I do mostly radiosurgery for brain mets. I rarely do whole brain. My oncologists at my institution are not big fans of whole brain radiotherapy for the most part, that they'll rather just keep doing systemic therapies if it's a whole brain patient. That's our practice. Yeah, thanks.
Thank you. And sorry, I have another question.
Yeah.
What do you think is the best interval between like SRS followed by whole brain or otherwise whole brain followed by SRS? Because
you mean the time?
Yeah. It kind of varies. Yeah.
I don't really have it. I think it just depends on their MRI scan. So like if I don't generally plan to do both. I'll usually, like if it's SRS patient, I'll do an SRS patient, and then I'll do MRI scans every 2 to 3 months.
Okay.
And then I either will just do more SRS, or if I need to, I'll do whole brain if there's a lot, like there's a really high brain metastasis velocity. So usually it depends on the MRI scan. If it's stable, I won't even go whole brain. I defer whole brain if I can for most patients.
I see, because those are the questions I've been asked by neurosurgeons and other colleagues. Like, is it okay for only 1 week? Like, or
post-op,
like,
you mean?
Yeah, or post SRS followed by whole brain RT, something like that.
Yeah, I rarely combine both. I usually SRS most, and then whole brain I reserve sort of like if needed.
Okay.
That's just my practice. Yeah.
Thank you, Professor.
Yeah.
Thank you.
You're welcome.
还有其他人有问题的话，就私底下问，因为时间到了，不好意思。
谢谢。
拍谁？你就私底下问。OK。